Opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors. Welcome to the wonderful world of wellness with the famous Dr. Andy Mencia. Dr. Mencia brings you his own show, which brings you medicine and other wonderful products in the field of health every Monday night at 6:30 p.m. here on WNN AM 1470 Radio, and live streamed on www.wonderfulworldofwellness.net. Brought to you by the Adult and Geriatric Center of Florida under the medical direction of the geriatrical doctor, Andy Mencia. Call and be part of the show at 888-565-1470 and let Dr. Mencia help you find a future with wellness.
Well, good afternoon and welcome back. And if you are driving, please be careful. If you're going to call in, make sure you have us on speed dial. We will put the phone number on the screen for the people calling from out of state and also for people calling from outside the country. We have a few calls coming from Germany now. So make sure you do dial the direct line if you're calling from outside the country. We want to welcome our audience back this beautiful Monday. The weather here in South Florida is just wonderful. It's great. A little bit hot toward the afternoon, but we are enjoying. We are having fun. Reminding everybody during the month of May in the United States is Stroke Awareness Month, the month of May. All of the show have basically been geared toward awareness of stroke and other conditions that can eventually increase the risk of patient having a stroke. And one of those conditions is when you have a problem within your heart, and not necessarily with the circulation in the heart, but sometimes with the valves. And if you recall, in your heart we have 4 valves, and 2 work intrinsically inside the heart, and 2 of them work extrinsically, allowing blood to flow in, and 2 allowing the blood to flow outside the heart. So those parts becomes very, very important. And I'm so happy to have today 2 wonderful people from the VAR clinic at Delray Medical Center. Kathy Malcolm Bozza, she's a ALNP, and the wonderful Dr. Jeff Newman, who is the medical director, right, Jeff?
Yes, that's right.
And you've been working there for a while, right?
I've been at Delray since 1996 and medical director of the valve clinic for about 8 months now.
Excellent, excellent. And Kathy, you've been also working there at Delray for in the capacity of a nurse practitioner with the clinic.
For about 2.5 years.
2.5 years.
Mm-hmm.
Excellent. I'm so happy to have both of you here. And the objective of basically the show is just to bring awareness. That's what we want to do, bring awareness to people. People in West Palm Beach, sometimes they have a condition, they listen to the show. And many times, Kathy and Jeff, we go to the primary care doctor and they will tell us, oh, you have a murmur. And they leave it at that. There is no echocardiogram, there's no EKG. Maybe you get an EKG once a year. But sometimes a murmur has different grades. And is that important for the patient to know, well, what grade is my murmur, what type of murmur do I have?
Absolutely. A murmur is a symptom or it's a physical sign that people can hear when they put a stethoscope to your chest. A murmur in and of itself is not a clinical sign of a valve problem per se, but it may indicate that your physician needs to look at what's going on inside your chest or inside your heart with some other tests, like for instance an echocardiogram, just to start a non-invasive type workup to see if you have a real problem or not. I've seen many patients that have told me that they've been told they have murmurs since they're 10 years old, and clearly when they were 10 they probably didn't have any cardiology or cardiac pathology that was going to require any treatment. But as we age, murmurs can change or become problematic.
And also with certain medical condition, For example, if a person becomes more anemic than usual, that will alter the grading of the murmur, right?
That's true.
Yeah. So it's important that if you have a murmur, just like people that have diabetes, they come nowadays, there's so much awareness about hemoglobin A1C that they come and they say, I want to make sure you get my hemoglobin A1C. But they just say, oh, they told me I have a murmur. I say, well, do you know what grade it is? Did they tell you what was the cause of the murmur? Or the etiology? And basically, no, they just told me I have a murmur and I have it for many, many years. When a person has a murmur, how do they grade that? What's the grading?
Well, when somebody listens to your heart through a stethoscope, they grade it based on its loudness,
Okay.
and also the duration during the heart cycle. And sometimes you can tease out whether it's a pathologic murmur or not, and other times you have a murmur. And the real key is, if you have a murmur since you're 10 years old, has it changed by the time you're 50 or 60? If it hasn't really changed, you probably don't really have a problem with your heart. But if it's changed and somebody can document that, then you probably need to check it out with some sort of diagnostic test to determine whether it's causing a problem or not.
Okay. Well, for those of you that take note, remember we had Dr. Jeff Newman. He's the medical director of the Bar Clinic at Delray Medical Center. Their phone number is the toll-free phone number you can call. It's basically like my practice. It's all under one roof, but their devotion is basically to your heart and in particular to the bar. And you can call the center at 855-368-7687 or 855-3-MURMUR, M-U-R. I broke the numbers down for you so that you just have all the number and you have the phone number if you have any question. When you call the center, they have a full staff from secretary to sonographer, Kathy, who is a nurse practitioner, and then the different specialists that will work at the center to make sure that you are well taken care of. So the center, I understand, is one of the first one in south of West Palm Beach?
That's correct, in South Palm Beach County.
South Palm Beach County. Okay.
So we started it to create a one-stop center, so patients who have been told they have a problem or patients who want to investigate a problem can come, and after several hours at the valve clinic, we'll leave the valve clinic knowing that they either have a problem or they don't have a problem, and what the potential is for fixing it or not fixing it, and we will give them full information as they're leaving the center. So all that'll happen within 2 or 3 hours of coming to our clinic.
So I hear that you have an interest in robotic procedures.
I do. I'm doing robotic lung surgery. I'm not doing robotic heart surgery.
Okay, tell me about that.
Robotic lung surgery is, we use the Da Vinci robotic system, which allows us to make port or half-inch incisions on the chest wall. And in most lung surgeries, we make 4 incisions at different spots, and then we dock the so-called robot to the patient and manipulate the lung and get whatever part of the lung needs to come out based on where a tumor is located.
Oh.
And what that does for the patient, it limits chest wall trauma, and it also decreases the amount of pain the patient's going to experience post-operatively. And we've had patients leave the hospital in 24 hours after having half of either the right or left lung removed.
Okay, but the mitral-valvuloplastic, and is that done robotically, or they have to be with an open chest wall?
We are doing many procedures on mitral and aortic valves. We're not using the robot. Quite frankly, I don't see the advantage in using the robot for heart surgery.
So
And
they
that's
can
a-
go through the catheter, like...
the robot still, even if you use the robot, you have various port incisions that you have to do to the patient to access the heart and stop the heart, put the patient on the heart-lung machine. I think there's too much involved to do robotic heart surgery. So we're just limiting the length of the incisions, or doing so-called mini incisions to minimize the trauma to the chest wall with heart surgery.
Okay. And Kathy, when the patient come to the center, Basically, you will do the initial intake. You're the person responsible for getting all the data together and so that you and the team can determine which route you're going to do with the patient, how they're going to follow.
Yes, I'll do the intake. I'll do a little bit of a history and physical on the telephone, make sure that what they're calling about is appropriate for the clinic. And yeah, I do all the initial workup and bring them into the clinic. They do their blood work. They'll have an EKG.
But you will order all this thing even before?
Yes, it'll all be in the works, and
Excellent.
when the patient is there, and one after another, and then Dr. Newman comes in and reviews all of it.
Okay. Now, when you do that, if you need an echocardiogram on the patient, do you send the patient across town to get the echocardiogram done, or is that done right in-house?
Right in-house.
So the technician,
They come right to the room.
the sonographer is able to come to you and to Dr. Newman and say, well, this is what I see, and that's so priceless, to be able to communicate this way, verbal communication among all the staff, where the patient is basically in the center of care. Because nowadays everything is so segmented that you go to see Kathy in one office, then Kathy send you to the hospital to get the echocardiogram, or you go to Quest to get the blood test done, or LabCorp, or what have you. And then the patient is calling you 3 hours later, Kathy, did you get the result? You say, no, it went all over. But everything is centralized, which means the result come to you much, much faster. And then by the time Dr. Newman get there, basically, you guys are able to put the picture together a lot faster.
Yes.
Excellent. And the patient, they can call in and basically request that they want to see you. I want to see Kathy Bolson because I heard the show and get an assessment.
They can call the 855-3-MURMUR number, and the call will come to a call center, and it'll get to me, and then
Okay.
I'll talk to the patient directly.
Now, from when the patient get there, if I hear the show, I hear all the program out there, and I hear about what's been done at Delray Center. From the moment I see you to the moment I get to see Dr. Newman, it's a long period of time. I'm already there. I'm there for my appointment today. And what is the lapse time between you and all the procedure and then seeing my specialist?
Usually about 2 hours.
Beautiful. Wow. That's excellent.
And they leave with a recommendation from Dr. Newman.
So they don't go home with, pulling their hair and taking Xanax and blah, blah, blah. They
No,
can
not
just
at all.
basically
No.
know that they're going to get an answer or get some guidance from Dr. Newman that day.
Yes, they'll leave with a recommendation.
Right, they'll have an answer in the sense that will give them a diagnosis if they have a valve problem that needs to be treated surgically, whether their condition is a medical problem that just needs constant monitoring by a cardiologist, which, by the way, we have a team of cardiologists that we refer the patients to after they come to the valve clinic that they can follow up with if they don't have their own cardiologist and are looking for a local cardiologist.
Excellent.
So we have cardiologists basically on standby that we refer to once we meet the patient.
And I think, Dr. Newman, one of the things that we should bring about is that the clinic is right there at the medical center, right?
That's true.
So if anything, patient can just go right into the OR. If it's a case of an emergency or something like that, they don't have to really be transported anywhere. It's right there.
That's
Everything
true.
is there.
That's true too. But hopefully, if they're coming in for an outpatient visit, there's no emergency situation going on. That's correct.
Right, exactly. But in case they know that they are in a center that if things need to be done, and time is of the essence, that you basically are there. I mean, there's so many times a patient come in and, they might be developing chest pain while they are waiting. And it happens all the time. And at least when you are in a freestanding center, like my center, if I have a patient with an acute angina, acute chest pain, I'm going to have to call 911 and transport that patient out. What you guys done? You guys have it right there, and that's, to me, that's you're talking about the heart. So I think that's very, very convenient to have that service there.
No, that's true. We have the capacity to treat any patient that has an acute problem I would say, God forbid, if they were in an outpatient setting.
Exactly. We're talking about prevention here, but I want people to feel comfortable that this is not a freestanding, this is a center that once you are there, regardless of how severe your condition is, once they come to the Ray Center, that they will be seen by Kathy and by you, and if anything need to be done, they are basically right at the center. There's no need for transportation or going anywhere to have anything done. So Kathy, in order to become a LNP, nurse practitioner, that means you were a nurse before that, right?
Yes.
And what inspired you to go into nurse practitioner?
Well, I love nursing, and I wanted to advance my career and I guess see it full circle.
Exactly. You are able to do more. You are closer basically to the thing us physicians are able to do with the patient.
Well, I collaborate with the physicians.
You collaborate with the physician, and I use nurse practitioner in my center, and I think, you guys are wonderful, and, you bring so much to the table when it comes to the care of the patient. And sometimes, the patient, they don't appreciate that. They don't understand that because they say nurse practitioner, they think, well, it's just a nurse seeing me, what about the doctor? But basically, you can do a lot of the things that we can do, except a few limitations here and there. You basically can take a full history just like I can. You can dictate a plan of treatment, a plan of diagnostic workup on the patient just like I can do. Okay. And the major difference between you and I is that you get to work next to Dr. Newman, and I don't. So I'm sure if he sees my history on physical, he's going to say, "Okay, Kathy, to the rescue here." So I think that's a big plus. Is and a lot of my patients, once they get exposed to your profession, they don't want to see other doctors. They're happy to see the nurse practitioner. And one of the main things is that you guys get to spend a lot of time with the patient. You really get to know the patient. And sometimes time is very limited to us as physicians. So, I try to educate the patient on how significant that is. Because, and Jeff, you will agree with me, when we're teaching the student, we say, 80% of the diagnosis is going to be in a good history and physical examination.
That's true.
So, and they do that, our nurse practitioner, they do that for us. They put things together that we didn't even think about. And say, this is what I have seen, and other conditions that we might come into play that can maybe contraindicate the surgery or contraindicate certain procedure. And the final outcome, what we want is patient to do well at the end of the day.
Absolutely. That's we want to make the correct diagnosis and institute the correct treatment plan. And I think at Delray, I think there's a team of about 12 nurse practitioners that assist in making sure appropriate histories and physicals are being done and the treatment plans are being carried out, and also act as intermediaries between the patients. Sometimes they have concerns that the physician's not in the building or operating or just not available, that the nurse practitioner can find out what the problem is and then relay to the physician and then get treatment for any kind of change in course that'll be more rapid than if a floor nurse has to get in touch with the doc and communicate what's going on with a particular patient.
Right. Assist a lot, yeah.
And what I'm finding now is we have residents and medical students rotating in the hospital now, and they don't know, clearly they don't know, or they're just becoming, I guess, aware of what happens in a hospital setting and the care of patients, and they're learning from the nurse practitioners what to do to how to take care of patients.
Exactly. Well, I tell you, when I went through medical school, and it was non-traditional, it was the modular system. And I remember the first module was taught to us by nurses. And basically that brought, and the objective was to bring a lot of cohesiveness between those future doctors and nurses, and appreciation for their years of knowledge and that they bring to the table. That sometimes us doctors get on our big horses and do not appreciate that. And like the sonographer, and they all bring in their expertise to the table, and that's what makes you and I shine as physicians.
Exactly. They approach patients from a different perspective than a physician, and I think it's just as important as what the physicians do. And it's not one's better than the other. It's just a teamwork of healthcare.
So to tell me about your your expertise as a thoracic vascular, thoracic cardiothoracic, because you do lungs. So I want.
Yeah, I'm a trained thoracic surgeon.
Thoracic surgeon.
So I do surgery of the chest, and which includes the heart and lungs.
Okay.
And I've been in South Florida since 1995, at Delaware Medical Center since 1996. And actually, I've gone through my recertification exams twice so far. That's how old I am.
We won't tell them how long it takes for each recertification, so we'll keep it there so they don't try to. No, you look very young, so you probably started when you were high school or something.
You're right. So it so happens in my practice, I do adult cardiac surgery, which is coronary bypass surgery, as well as adult valvular heart surgery. And that represents probably about 50% of my practice of surgery.
Okay.
And I also do pacemakers and everything that related to pacemaker type surgery. And I do lung resections for basically lung cancer. And that's the scope of my practice.
Okay. Now with a pacemaker, you do the traditional pacemaker, the ICD.
I do all of the above,
All of the-
transvenous pacemakers, and now we're also doing what's called the subcutaneous cardioverter, ICD, or cardiac defibrillator, which means you don't have to gain access to the venous system of the patient's chest.
Mm-hmm.
So they think it's a little safer long term.
Right. And the recuperation period also is much faster, right?
Exactly. In the subcutaneous ICDs, we've actually had patients go home the same day rather than having to spend the night.
The hospital. Wow, that's wonderful. That's great. Now, people that are listening, they say, I have a valve condition. I better start running there and make an appointment. People can have a murmur and be completely asymptomatic, and like I think you mentioned that before, they can have a completely normal life, right?
Right, that's true. A murmur in and of itself is not a diagnosis of anything other than a murmur. It's a physical sign.
Mm-hmm.
But if you do have a murmur and you're worried about it, it needs to be checked out by some diagnostic test.
Now, why don't we explain to the audience the VAR, because the VAR is like it's not a two-way door, it's a one-way door. It's what goes out the VAR is not supposed to come back.
That's true. I mean, what we're seeing now is that as our population ages, and certainly South Florida has a population that's very common to see people in their 70s and 80s and even 90s. The most common valve that we have to deal with is the aortic valve, which is a valve that sits on top of the heart. When the heart basically pumps to eject all the blood out, that door opens and all the blood is ejected out. As we age, that particular valve, called the aortic valve, gets calcified, and that might impede how wide it opens, and so it starts to narrow, and that puts pressure inside the heart, because as it's narrowing, the heart has to work harder to eject the same amount of blood out. We call that aortic stenosis.
So the two major condition of the VAR is the narrowing of the VAR or the insufficiency of the VAR.
There is also aortic insufficiency or a certain amount of leakiness.
Mm-hmm.
That's actually less common than aortic stenosis, but that can be problematic as well. But in most people that are getting on in age, aortic stenosis is the problem that we see.
Okay. And so the two major valves that get the blood outside the heart, you say the aortic valve, and that basically sends the blood through the entire body, to your brain, to your legs, to all the organs.
That's right.
And then the other one would be the pulmonary valve, right?
Right, and that's on the right side of the heart. And that valve very rarely becomes problematic unless you have a congenital anomaly. So we're talking about excessively rare that we have to operate or treat that valve.
So congenital means you are born with that condition. So you're saying that some of this valve condition can be seen in newborns and kids?
That's true. But that type of valve condition would be recognized probably in the first couple of years of life, and a pediatric heart surgeon would have to deal with that patient.
Exactly. That's a subspecialty there.
That's right.
There are people that just work with kids and newborns. And Now, talking about hearts and heart condition, a lot of us that have kids and they are into sports, we hear about teenagers having sudden death and, some of these people playing basketball. Why you elaborate a little bit on well, I think we have a call coming in. Let's take this call. Caller, you're on the air.
Yes, my name is Renata, and I have a question to Dr. Newman about the valve.
Renata, are you calling from Germany?
Yes.
Guten Tag.
Hi, Renata.
Guten Abend.
Guten Abend. Wie geht's?
Danke gut.
Danke gut. Good. Okay, question for Dr. Newman. We get to practice German a little bit.
Yes. There is a valve, and this valve has some plaque on it. And my question is this plaque dangerous?
So the question is if there's plaque on the valve, is it dangerous, correct?
Yes.
Okay.
Only, in general, no. As we get older, if the valve is if the plaque is restricting the movement of the leaflets, which open and close, then it might become a problem. In general, these plaques don't break off. What I see when I operate on patients who have aortic stenosis is it looks like calcium or boulders are building up on the valve leaflets. And I think that has to do with trauma that happens as we age. The valve has to open and close millions of times as we live. So that's why we're seeing people in their 70s or 80s developing calcium and calcium deposits on the valve because the valve is constantly exposed to its own opening and closing traumatic experience. And so while plaque in and of itself is a problem in coronary arteries, on the valve it's more calcium that we see, and it literally looks like boulders or rocks on the calcium.
Is this then when people get then this beta blocker?
Say it again, Renata.
People get then this beta blocker.
Oh, beta blocker.
A beta blocker, again, is good for blood pressure and controlling how fast your heart goes, what your heart rate is. It's not going to do anything to prevent plaque buildup or aortic stenosis.
Oh, okay.
Thank you, Renata, for your call.
Thank you very much for your answer.
Auf Wiedersehen.
Auf Wiedersehen.
And to the audience, Auf Wiedersehen also, but we are just coming for a little while. We are not saying goodbye. We'll come back in a few minutes. We're going to take a short break. Don't go away.
Tired of long waiting times at your doctor's office? Are you frustrated with driving all over to see your specialist doctor? Are you looking for compassionate and knowledgeable medical professionals who can truly help you? Look no further. Adult and Geriatric Health Center, under the medical direction of Dr. Andy Mancia, is a multi-specialty medical and dental center devoted to you. We have specialists in all areas: internal medicine, dentist, geriatrician, pulmonologist, cardiologist, podiatrist, neurooptometrist, ophthalmologist, neurologist, dermatologist, urologist, infectious disease specialist, dietitian, allergy testing, and hypnotist. Located in Fort Lauderdale, Florida on East Commercial Boulevard between Dixie and US 1. We are your one-stop shop for comprehensive medical and dental services. Check us out online, adultgeriatrics.com, and follow us on Twitter at AGI Health, Facebook, AGI Health Center, and LinkedIn, AGI Health Center. Call now to schedule your appointment, 954-489-1345. Do you know someone who drinks coffee? Of course you do. Coffee is the second most consumed beverage on the planet after water. It's the second most traded commodity after oil. People drink coffee all day, every day, in almost every country around the world. But here's a really powerful question. When was the last time you were paid every time someone enjoyed a cup of coffee? Welcome to Organo Gold. We're a company that is working to improve people's health, wealth, and bring more balance to their lives, thanks to the overwhelming power of Ganoderma, an ancient Chinese herb that has been used for more than 4,000 years to enhance wellness. Not only do we have coffee, but we make tea and hot chocolate so people of all ages can enjoy it. We also have supplements for those who don't drink coffee or tea. Visit MenciaCafe.com for more information and to start your road to wealth and wellness today. Dr. Andy Mancia's mission is to improve your quality of life by providing both convenient and affordable health care under one roof for our patients. By providing the best healthcare services to our patients, Adult and Geriatric Health Center can prosper as a business as well as to continue to meet and exceed the expectations of our staff and customers. Call us at 954-489-1345, 954-489-1345. And now, back to our show.
Well, welcome back. The raffle we're going to have today is going to be, because of the month of stroke awareness, it's going to be a free stroke prevention kit. And if we get caller number 5, they will take your name and we will send that to you via mail. Please call 888-565-1470, 888-565-1470. If you are driving, please be careful, and but do go for the stroke prevention kit, stuff that you can have to help you exercise and pace yourself and stay active. That is very important. We have a question that came into Twitter, and it's about poor circulation. So is poor circulation in the leg is a sign of bad heart?
It can be a marker that you're developing coronary artery disease. Certainly, you're at risk for having blockages in your coronary arteries as well as your peripheral arteries. And so it's probably not a sign that you have a bad heart, but it's a potential marker that somebody needs to look at, see if you are at risk for a heart attack.
Right. So, yeah, from the point of view of the geriatrician, basically, poor circulation is a systemic condition. You cannot have poor circulation on the leg and have excellent circulation on the arm and the carotid artery that have to do with the circulation toward your brain or your heart or other part of your body. So especially a person that had been a chronic heavy smoker, and they are telling you that you have poor circulation in your leg, you want to get checked. And one of the things that we are doing at the center is in anybody that has a history of smoking, we check the main valve that goes through the abdomen, called the aortic valve, and we're looking for aneurysm in the aortic valve, because it's highly correlated with active and ex-smokers. So if you have poor circulation, one thing don't dictate the other one, but yes, you want to make sure that either your primary care physician look into that, or if you have a cardiologist, that your cardiologist is made aware of the fact that you are having problem with circulation. Now we hear when we are teaching the student about the right heart and the left heart. Are they two different hearts, or just one heart that we divide in two parts?
It's one heart that we divide in two parts, and in the left heart supplies the circulation to the entire body, and the right heart supplies circulation to the lungs, but they actually function in a series. So as the blood comes back to the heart, it passes through the right side of the heart into the lungs, out of the lungs, back into the left side of the heart, and then out to the body. And so they're functioning in synchrony as a series.
So let's talk about the heart as a pump. And a lot of time when I'm talking to my patient about the ejection fraction and how well or how concerned I am about the heart. So we have this pump on the left side and the right side, and the main concern is the one on the right side, on the left side.
On the left side,
because that's sending blood to the entire body, right?
Correct. And and as Andy just mentioned, ejection fraction. And I like to give a simple analogy when I'm talking to patients about ejection fraction. If you have a heart attack, that's telling us that you've lost some heart muscle, so your ejection fraction of the strength, or the strength, the so-called strength of your heart muscle, has potentially diminished in its strength, if you will. So in general, a normal ejection fraction, one that we were born with, is somewhere around 60%, which goes to say if your heart fills with 100 ounces of blood with each cycle, it'll pump out 60 ounces. If you have a heart attack, that ejection fraction, or that strength, might diminish. Once it gets below 35% or 30%, that's when people start getting into trouble with symptoms of heart failure and shortness of breath. Mm-hmm. And that has potential longevity issues. People with low ejection fractions or weak hearts, we know, are at risk for arrhythmias and sudden cardiac death. So that's why it's important to protect yourself from a heart attack or get treated right away and try to protect your heart muscle from losing its strength.
Kathy, do you guys use over there any cardiac rehab or anything like that for patients with this heart condition, just to help them? Do they have a cardiac rehab center at Del Rey or no?
We have a rehab center, Pinecrest. It's not
Okay.
specifically for cardiac, but
But Dr. Newman, so if you send the patient for rehab, do you give specific instruction on what is it that you want your patient to do if you're not going to go through the surgery?
Well, in general, my patients go to cardiac rehab after having heart surgery.
After the heart surgery, okay.
And the cardiac rehab is more for gaining strength to conduct their activities of daily living and to rehabilitate themselves from the deconditioning that goes on in a hospital stay that might be a week to 10 days. So everybody gets a little bit weaker from just not taking care of themselves or not walking around every day. So cardiac rehab is more about conditioning their body to get out of bed, to walk up the stairs, to go to the bathroom, to make any meals at home.
And when the patient come in with the pump basically failing on them, the heart as a pump is just failing on them. Let me start with you, Kathy, because you do that initial intake. What are some of the symptoms, signs and symptoms that we see on them that, if I know that I already had a heart attack, is it just plain shortness of breath, or is it the person that is trying to talk on the phone, I cannot carry a conversation? What are some of the symptoms that we see on them that I should tell me, I should go and see Kathy and get myself checked on this?
well, symptoms of heart failure, shortness of breath, of course, being the most common, fatigue, sometimes dizziness, but definitely shortness of breath, edema
And they can be
legs.
depressed, right? Because you are not getting that much blood going to the brain, or they can have a picture that look like depression, right? Because you don't have
Yes.
that blood flow. And I tell you, Kathy, I've seen patients that have come to me that they think they have Alzheimer's disease, and when we do the entire workup, they end up seeing a cardiologist and not a neurologist. So, you agree, Jeff?
Absolutely, because patients they can have a depression because they can't do the activities they want to do. They feel like they're stuck, and a lot of patients don't believe it's their heart. They don't want. No one wants to think that their heart is getting sick, because that's
We don't want to face that.
correct, and it's a mortality issue, or nobody. And we see it a lot of times. I even see people denying symptoms that they're having. Well, I'll interview somebody that has had a cardiac catheterization for chest pain, and then I'll ask the patient in front of his wife, and I'll say, "How long have you been having chest pain?" "Well, it's really not chest pain; it's more like a dull ache." and the wife might not even known that the husband was having that kind of symptoms, and then it starts a family argument.
And a lot of time, I'm sure Kathy said this, I say it all the time, at least when they come to you, they know they are coming to a heart center. But when they come to me, sometimes they want to play it down, and they wait for me to almost leave the room, and they say, "Oh, doctor, before you go, I just want to let you know, I've been having this little chest pain." Yeah.
The
on
oh, by
out.
the way.
Yes,
Yeah.
oh, by the way, I'm having this little chest pain. I say, "Oh." So back we go.
It's more common than you think, especially in people that are matriarchs of a family never admit that they're sick, and they can very often I see them walking around for months, if not years, with stable angina that they're not telling any of their family members.
But the condition that you guys treat is a equal opportunity condition. I mean, are women exempted from this, and it's only men that should be worried about heart condition, or it's an equal opportunity? Everybody get a shot at it.
I think it's equal opportunity. I think the incidence is probably the same in both men and women. I think that men probably deny their symptoms more so than women. So although I'm seeing equal amounts of aortic stenosis in both men and women.
And I think with the awareness that we as a society have been bringing out there, both men and women now, they say they are being more proactive in trying to come in and try, at least try to get checked. I know some of the conditions that you can have because of shortness of breath. We didn't talk about the grading of shortness of breath, but it's not necessarily valve condition. Why don't we talk about other conditions, like how about can I have cancer in my heart?
You potentially can have. I mean, there is primary tumors of the heart of various different cell types that can cause shortness of breath if they act like a ball valve, if they get large enough.
Okay.
And also they can embolize, or debris can collect on these tumors inside the heart, and actually, since we're talking about strokes, can actually
Exactly.
cause a mini stroke or a big stroke for that matter. Again, it's something that needs to be worked up and we always do an echo on anybody that gets admitted with any kind of cerebral vascular events.
Now, we know that in certain organs, for example, pancreatic cancer, as a society of healthcare, we still have a long way to go. What about those tumors in the heart? Are we able to walk out of the hospital and live a normal life, or are they basically a death sentence?
No, it's absolutely not a death sentence. Most cardiac tumors are actually benign in nature.
Okay.
Once they are excised, assuming the surgeon did his or her job, patients should live a completely normal life and not even worry about having it come back. And we also take away the risk of a stroke.
Exactly. That's the most important part. Right. And so, and it goes basically, any cancer that you can have in your body increases the risk of developing clots, and developing any kind of clots, of course, increase the risk of developing deep venous thrombosis in your leg, and especially in the heart, because the circulation is shooting straight to go to the main blood vessel, including those that go to your brain. Then, of course, it will put you at risk of developing a stroke with any kind of tumor. So, if again the center is the VAR clinic at the Ray Medical Center, their phone number is 855. It's a toll-free phone number, so you can call from anywhere you want to. 855-368-7687. 7687. And Kathy, where are you guys located? Just to give some proximity of where the center is.
It's at Linton and Military Trail in Delray.
Okay. Do you get people from out of town that come in to get treated, or just basically local people that come in? When you're doing your intake, do you get people that come from other area, or?
Well, being that South Florida is so transient, we do have people from all over the place, all over the world, all over. So, but a lot of local.
A lot of local people also.
We also see a lot of snowbirds.
Exactly.
Who come see us, and a lot of times people that come who happen to be snowbirds are confused about what their docs up north have told them, and so they come to us for a second opinion,
I was
to
going to ask
explain
about. Good.
what was done up north, and they'll bring all the tests that they had up north, and we'll repeat the exam and give them a further explanation.
Okay. And when the patient do leave, do all of the patient need to go into blood thinner, multiple drug? How's your average care of those patients when upon discharge?
Most of the patients that have that leave the valve clinic, we continue on the same medicines, and the biggest thing is to identify whether they have a valve problem that needs to be treated surgically, or can it continue to be monitored.
And that's one of the beauty. I mean, I'm so happy when I meet a surgeon like you, because people have the misconception when they hear the word surgeon knife. And, I work with so many surgeons, and I'm happy to have you in the show today, because no old surgeon is going to tell a patient you're going to have to be open up to treat it. A lot of time, surgeon like you will say, we're just going to observe, and we're going to work with your modality of have you living your life just to help you prevent any surgery or anything like that.
I think that's true, and we've had patients leave the valve clinic who we've told that probably in the next 2 to 4 years they might need an operation. And I've even seen patients in my private office that come in and they're there to talk to me about heart surgery, and it turns out that their valves aren't severe enough to warrant surgery at this point. But telling them that assuming they live long enough, that they may require surgery. But we don't want to operate on somebody before it's time, because it's just not the right thing to do.
Right. It's like taking a person with a little arthritis of the knee at the age of 40 and do a knee replacement. We know that we're just creating problem for the future. If that can wait, let it wait.
That's true.
Yeah.
I mean, we're all better off with our own valves rather than
Exactly.
man-made valves.
Exactly. Well, talking about valves, people are concerned with the type of valve that we'll be putting in our body. Let's talk a little bit about the different type of valves that we have there.
Sure. There are two types of valves. There's so-called mechanical valves or metallic valves and tissue valves. The tissue valves are divided into pig and cow valves nowadays. And most often in our practice we end up using cow valves because we know that those valves in the aortic position will
It won't make me produce milk.
No, I won't do that. But it will last. In general, they last longer than our experience with the pig valves. When I say last longer, if you have an aortic valve problem that's replaced with a cow valve, you should get at least 15 to 20 years out of that replaced valve.
Wow. And and I guess if you get a mechanical valve, then the follow-up treatment changes.
Correct.
Right?
That's the biggest difference between mechanical and tissue valves. Is a mechanical valve requires Coumadin for the rest of your life to make sure that valve works well. And the issues with Coumadin include either your blood's too thin or too thick. If it's too thin, you have the potential for bleeding somewhere. Or if it's too thick, the valve potentially won't work the way it's supposed to, and that would cause a problem with your heart. So, in general, nowadays we don't put in a whole lot of mechanical valves unless the patient is in their requests one because they don't want to look at potential redo surgery in 15 or 20 years, or that might be a patient in their 30s or 40s.
And the thing is, the mechanical valve is metal, so metal hitting metal is just breaking the blood cells. That's one of the concerns.
That's if there's a leak outside the valve, that might be a concern. But in general, we don't see a lot of hemolysis or destruction of red cells. Some people do complain that they have a click, and their significant other hears a clicking noise at night when they're asleep.
You don't let me sleep, you click over there. Put the heart on a beta blocker, like the caller from Germany says. Commissiotomy procedure, support ring around the valve.
Well, now you're talking about the mitral valve, and that's the second most common valve that we operate on, and we see a lot of mitral regurgitation or leakiness. We don't see a lot of mitral stenosis. Mitral stenosis is a byproduct of rheumatic fever, which we don't see a lot in the United States.
Thank God.
So with the mitral valve, what we're seeing a lot of is as people are living longer who have had heart attacks, their heart muscle might enlarge or dilate, and that affects the function of the mitral valve. So as Andy just mentioned, support rings, we can narrow the orifice or the opening of the mitral valve with a mitral valve ring that'll allow the valve to work more appropriately without the leakiness. And again, that'll preserve heart muscle function because we can change the natural history of mitral regurgitation.
And you still get patients coming at us and they say, oh, I saw Dr. Newman in 1990 and he told me I have to get prophylaxis treatment every time I do dental work, and don't change that because this is what that have changed, right?
Yes,
the indication for prophylaxis.
Correct. If you have a murmur and have never been diagnosed or have never been operated upon, there is no or so-called mitral valve prolapse might be the most common disease.
Mitral valve, right.
There's no indication to give dental prophylaxis. However, if you've had a history of heart surgery, a valvular heart surgery, and they've placed some sort of prosthetic ring or a prosthetic valve, you absolutely need dental prophylaxis.
Okay. And in our center, in the Adult and Geriatric Institute, we have a dental department, we have cardiologists, we do vascular procedure, dermatologists, podiatrists, ophthalmologists. So with all the specialty that we have there, a lot of times the dental department is calling us and asking, do I need to prophylax this patient? The old-timer, they still want to go with the prophylaxis and say, you really don't have to. It won't harm the patient, but you really don't have to do that.
That's true.
Okay. Excellent. Very good. Kathy, when the patient come to the center, I understand you do have, the patient is going to get electrocardiogram They might get a chest X-ray. What are some of the ancillary services that your center can provide for the community, such as echo, MRI? What kind of tests do you normally? What is the normal thing that you order, day in and day out?
Well, we have all types of services at Delray Medical Center, but at the valve clinic we utilize the laboratory, the phlebotomist, EKG, echo, and
But the echo is done at your center, even though inside the hospital, right at your center.
it's right in the exam room.
Okay.
They don't
excellent.
have to
They don't have to
go
go
all over the
anywhere.
hospital. The phlebotomist comes to them for a blood draw, EKG comes to them, echo comes to them.
And now, when the patient do come to you and you guys have taken a case that you will proceed with surgical intervention, do the team will follow the patient also through the hospital
Absolutely.
stay?
Absolutely.
Okay.
From
And
start to
then,
finish.
Start to finish. And then afterward, then they are follow-up, then they will continue with you.
They continue with their cardiologist
Right.
at that point
right.
upon discharge. They don't follow up with us after discharge.
Okay. So, but at least, during this important period, there is continuity of care. That
Absolutely.
That is so important, Jeff. I mean, when we have patients coming in and, you get seen in one center and then they ship you elsewhere.
Right, they'll see a familiar face.
They'll
They'll
see
see Kathy during the hospital stay. They'll see me more than once a day, and they'll also see the cardiologist that's involved with their care. And in general, as patients move farther out of the time frame or move away from the date of surgery, the surgeon becomes less important in their care, and then it becomes a medical issue.
become a medical issue, right. Excellent. What kind of complication we try to avoid, and what can I do as a patient if I'm going to come in? For example, if I drink, if I smoke, what can I do to help you do a great job on me at the end of the day?
That's a great question. I think you mentioned alcohol. I think alcohol in moderation is not going to affect heart surgery, your heart surgery in any particular way. But I think, and I've explained this to a lot of patients, if one smokes on their way into the hospital to have surgery, they're going to make the surgeon's job harder as well as their own job harder, because it's really going to affect what their lung function is and potentially put them at risk for pneumonia. Specifically because we're operating in the chest.
Right.
So that's going to affect lung function. So I tell patients, even if they can refrain for 5 days prior to surgery, they need to stop smoking.
Kathy, what about diabetic patient? I mean, if we have a procedure that is going to be scheduled 2 or 3 months from the day they are seen, do you send recommendation to the primary care doctor, or do you follow that patient to make sure? Because as a geriatrician, one of the things that I try to do is make sure the sugar is tightly controlled, so that when Dr. Newman is seeing my patient, that they are the least amount of complication possible. So do you work with those patients with diabetes too, or do you refer them out? You work with a primary care doctor to make sure that we get all of those risk factors under control?
Absolutely, and actually diabetes is one of my favorite subjects aside
Good.
from the valve clinic, but diabetes and keeping it under control prior to surgery and throughout the hospital stay and post-surgically, has been shown to have better outcomes, less infection. So absolutely, and we do work with the primary care physician. Again, it's a team approach, not only just us here at the valve clinic, but we want to include the primary care, if they have a cardiologist, endocrinologist, everything to keep the patient as well as possible.
And that is so important, because if you have diabetes, they're going to open the tissue, they're going to open your skin, they're going to go different layers, and then you're going to go through that healing process. And it has been shown over and over again that a person that have their sugar very well controlled will heal a lot faster, no complications, you're just going to heal a lot faster than a person that had the sugar poorly controlled. And I used to work in Mount Sinai Hospital, and one of my major rotation was to clinical microbiology. And I tell my patient, when we want to grow a bacteria, we take blood and sugar to make bacteria grow faster. So if your body have those, all of us have the blood, and some of us have too much sugar. So it is important that you try to get your sugar under control. Work on your smoke cessation. Be honest with Kathy and the rest of the staff when you are there, so that they can better work with you. I want to thank the staff from the Ray Medical Center, Courtney, for bringing us this wonderful expert to educate you. And it's always a pleasure being here with you. Please take some of this information. Before we go, do you guys have a website? Hello. People now, they love website. Gonna put them on the spot, but that's okay. This is live TV, so.
Well, Delray Medical Center has a website.
Okay.
And you can access the Valve Clinic website from the main site.
Okay, great.
It's DelrayMedicalCenter.com /Valve Clinic.
Okay. DelrayMedicalCenter.com /Valve Clinic. Go on the website. You can look at Dr. Newman's credentials and the different things that he can do at the center. A lot of more information that in this 1 hour we could not bring there. And I hope you have enjoyed the show. And again, this is Dr. Andy Mencia from the Adult and Geriatric Institute in Fort Lauderdale, Florida. We are located at 1608 East Commercial Boulevard in Oakland Park. Our telephone number is 954-489-1345. Have a great week, and God bless you all.
You have been listening to The Wonderful World of Wellness with Dr. Andy Mencia, who is a 2-year fellowship-trained geriatrician and owns a large, multi-specialty geriatric center in Fort Lauderdale, Florida. He believes in caring for the elderly in the most compassionate way, and to that end, he created the center with them in mind. Join Dr. Mencia every Monday night on the WWNN 1470 radio TV network and on his website at www.wonderfulworldofwellness.net to ask any questions on the many topics he covers.